Specialty Story, session number 103. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, and I am excited to be back for another week where I get to talk to an amazing physician, this time a program director, an otolaryngology program director. And we're going to talk all about what you should be doing as a medical student if you are interested in matching into ENT. Now, obviously, what we talk about today isn't specific to ENT, although our guest today is an otolaryngologist and is a program director for ENT, but the advice that she gives is great for every residency that you are going to be applying for. And we also talk a little bit about women in the operating room as well. Let's go ahead and jump in and talk to Dr. Christina Cabrera-Muffly, who is an otolaryngologist who's been out of training now for 10 years and is the residency program director here locally at the University of Colorado. We start the discussion by talking about when Christina first became interested in ENT.
Yeah, so I went into medical school with a pretty open mind. My dad's a doctor, he's an OBGYN, and I had volunteered at the hospital and I had followed him to the OR and shadowed a few times. I really liked the OR environment. It was just very meticulous and detail-oriented, and the camaraderie of working with the team to get a patient outcome was really interesting to me. So when I got to medical school, I thought maybe surgical, but I wasn't sure. And then I actually fell in love with my pediatrics rotation, which was shocking to me. I wasn't really a kid person before that, but I loved the continuity of care. I loved working with the kids. And so then I did an elective, an otolaryngology pediatrics elective. And that was when I knew, because it had the best of both worlds. I could see adults, I could see kids, I could do surgery, I could treat patients medically. It's one of the few surgical fields where you can actually see kids without a long fellowship afterwards. And so I thought that would be really a nice option for me.
What was it that kind of got you into the ENT elective, right? There are a lot of surgical electives for peds. How did you stumble into that one?
Well, so most of them didn't have pediatrics. So the surgical electives were urology, orthopedics, ENT. I forget the other, anesthesia, I think was another one. But most of them were at the main hospital where I did my medical school. They had one at the pediatrics hospital for ENT specifically. So I think it was, Providence that led me to that.
Ah, interesting.
And, I think things have really changed since then as far as medical student electives. We, for example, at University of Colorado recently lost the ability for medical students to do an otolaryngology elective at all. They have to do a full rotation when they're in their fourth year, but they don't get to experience any otolaryngology unless they shadow on their own time during their surgery block anymore.
It seems like time is becoming more and more an issue. And that's kind of the purpose of why I started this podcast, is that during medical school, there's not enough time to appropriately evaluate everything. And so let's just have some conversations with physicians and let people know what potentially they should even be looking for an elective.
Absolutely. Yeah, it's hard enough to figure out whether you want to do something surgical or medical, and then there's so many offshoots of that, branches that you could go down. So having that opportunity is really, really critical.
Yeah. What do you think, what traits do you think make for a good otolaryngologist?
I think being able to relate to people is really important because we're not pathologists. We actually do see patients in clinic, and
the future pathologists are like, no, I'm going to talk to patients.
Yeah, they don't really talk to patients that much. So yeah, I think having an ability to establish a good rapport with patients, I think many people, most people can be surgically trained. I think it's more this kind of ability to synthesize the knowledge and to translate that into who really needs surgery and who doesn't. That's a little trickier. So the ability to do that. And I think, in our field, especially, people have trouble communicating. We do more with communication than almost any other field. We see people who are hard of hearing. We see people who have lost their ability to speak. So being able to interact with people that may not be able to communicate with you is also important.
When it comes to the types of patients that you are treating as an otolaryngologist, you mentioned potentially people who can't hear you, potentially can't speak. What sorts of pathologies are you seeing as an otolaryngologist that students would potentially see?
So it's really interesting because it is a very anatomically specific field, but very wide ranging otherwise. So one day I can see a jawbone mandible fracture. Another day I can see hearing loss. And actually not even at different days in the same clinic. I can see someone with a deviated nasal septum who can't breathe through their nose, someone who's had a stroke, who's had trouble verbalizing. So they, we figure out whether the vocal cord dysfunction is part of that or not, or if it's an enunciation issue. So it's a pretty diverse set of skills. I think it's one of the nice. You can decide if you don't want to choose one thing. You can decide to do everything in one particular anatomic area. That's the way I think about it.
Describe a typical day for you.
So I'm a generalist, which means that I see more patients in clinic than some of my other subspecialist colleagues. So for example, a head and neck surgeon who sees cancer patients is going to spend a lot more time in the operating room because they're doing 12-hour free flap microvascular procedures and other big head and neck cancer resections. Whereas my cases are generally 1 to 3 hours in length. And my typical week, I should say, is seeing probably 2 to 3 days of clinic and then 1 to 2 days of operating room time. And I'm doing bread and butter ENT, as I like to call it. So tonsils, ear tubes, sinus surgery, septum surgery, excisional biopsies, most of that stuff. And, depending on what you like to do, if you want to do ear surgery or laryngology surgery, like if you have a vocal cord lesion, you can excise it. Those kinds of things, you can do those as well.
And what was the decision for you to stay a generalist versus going in what seems to be the general direction for a lot of medicine is being a specialist?
Yeah, I really enjoyed multiple parts of otolaryngology. So I didn't want to just do, nasal surgery or just do ear surgery or just do laryngeal surgery. I wanted to be able to do all of it. And, as I've continued to practice over the last 10 years, I have narrowed down my focus somewhat and don't do some of the more kind of, gigantic procedures. But it's a very satisfying thing to be able to treat multiple things at once. So it's interesting when I do clinic at the main campus, all of my partners pretty much are subspecialists. So they see patients who say, I can't breathe through my nose or I can't hear. But if a patient calls and says, I can't hear and I can't breathe through my nose and I've got this spot on my tongue, they see me and I can actually treat all of that at once, maybe not at once, but all of those things without having to send them to 3 different people. So that's very satisfying. But I also have the luxury of being a generalist in a university practice. And so if there's something that I feel like would be better served by a subspecialist, then I can refer on to my partners and I know that they will be taken care of.
Now, for you, what was the decision algorithm for being in an academic center versus going out to the community?
Yeah, so my first job was actually at an academic center. I think, it'd be silly of me to not attribute some of this stuff to lifestyle, right? So as a general, I chose general because I really liked general and not choosing one thing, but also because I was getting to the time of my life when I wanted to start having a family. And so it was not having another year of fellowship. And so instead of me going to fellowship, I followed my husband, who's a surgeon, to his fellowship, and then got an academic job at the same hospital where he did his fellowship. And so it opened my eyes to academic practice. I fell in love with that. It wasn't something that I considered or sought out at the beginning, but it was something that really was satisfying to me. And I ended up being an associate program director while we were there and just fell in love. And I thought, this is something that I can do to make a difference for, future generations. Basically, we always talk about having a legacy. I mean, I can see, however many patients a week and make an impact. But if I can train someone and multiple people, multiple residents, and then they go on and treat more patients than I could ever treat in a lifetime, then that is very satisfying to give back to that legacy. So,
yeah. A little exponential impact there.
Exactly.
For a medical student thinking about ENT and trying to understand what that path looks like, what does the path look like to become an ENT doc?
Yeah, so ENT continues to be one of the most competitive specialties to get into, which it's unfortunate for applicants, fortunate for us because we've got plenty of great candidates to choose from. So really, it's difficult for people who don't have the either clinical rotation grades that they should have or the step one score or research opportunities that they should have to really attain a position. It's really interesting too, because over the last 20 years, really, ENT has always been known as very, very competitive, and the step one scores have gone up every year pretty much until they hit a peak 5 years ago, where they had a mean of 250.
Oh.
And then I know a pretty significant score, which, by the way, I didn't get anywhere near that, but, and somehow I got in. So, but then 3 years ago, actually, so not this match cycle, but the previous two match cycles, all hell broke loose. And we had 14 unmatched positions in 2017 and 12 unmatched positions in 2018, which is unheard of. We've never had more than 1 to 2 unmatched positions ever.
And you're talking about every program, not just your program.
Yes, this is nationally, right? So there's approximately 300 something positions every year. And so the reason that we didn't fill those 2 years, my program filled, but other programs had openings, is because fewer people applied. So instead of having 400 applications, we had 300 applications for 2 years straight. This past cycle, it actually swung again. The pendulum swung again. And so we had about 450 applicants this year. And so there were a lot of unmatched applicants, which again is incredibly unfortunate, because looking at these applications, I mean, these are incredibly accomplished people who, deserve a position. I could have interviewed, at least 300 to 350 of these applicants and been satisfied with having them as a resident.
Why do you think ENT is so competitive?
I think because of the supply and demand issue. So there's really only 320 positions. So, it's a lot of people want to do it. I also think, not to pat ourselves on the back here, but we are also known as the nice surgeons, right? So, we tend not to throw things in the OR. Not that other surgeons do, but it's one of these things where you cultivate this reputation where, for a surgical profession, you can have a decent lifestyle while making a huge impact, and there's just not that many positions.
Yeah, that's it's classic supply and demand. The same for I'm looking at the match data right now. Same for like neurosurgery, right? Neurosurgery is even less than that. And when you think of the more competitive specialties, it seems to be a supply and demand issue. Not always, but lifestyle obviously is a big one. But for a surgical field, supply and demand definitely plays a huge part. So it's super competitive, right? Not a lot of spots and 400 applicants. If you think of the year you're talking about, 400 applications for 300 spots or a little more than 300 spots. What is a student supposed to be doing to help their application stand out and to get one of those spots?
Yeah, so I don't think you have to have a 250. We interview plenty of people who do not have a 250. I think it helps if you do. And I think if you don't, you need to have other aspects of your application that really help you shine. So other things are clerkship grades. We look at really the general surgery clerkship and the internal medicine clerkship as the key ones that really tell us how you've been doing. So honoring those is helpful, although a lot of medical schools have gone to pass-fail now. So you can't always tell how people did in their clerkships. The dean's letter does give you some insight, although again, the dean's letters are often cultivated to be, the most positive of the positive comments. And so it's hard. I think in the last 5 years, I would say the research output of applicants applying to otolaryngology has gone up astronomically. So whereas we used to see people who had one oral presentation or one poster or, maybe one publication, now that is actually the norm to have at least one, and many people applying have multiple publications. They may not all be in otolaryngology, they may be in orthopedics or general surgery, or even other, non-surgical fields, and that's fine, that counts. But it's really interesting to see that evolution over the last several years.
For an applicant who is a pretty easy no from you guys, from you specifically, when you're reading an application, what is on an application that kind of makes you go, yeah, no, this is like the board score may be great, but I'm going to pass?
Yeah. So I think someone who doesn't have anything else, so I don't care if your board score is 280, and I have seen one or two of those over the years. If you have no volunteer activities, if you haven't participated in any research projects, even if those haven't led to publication, if you have nothing to list in that section of your application, if your letters are mediocre, and there's code for letters. I don't know if students know this, but there's when you have a statement like top 5% of students I've ever worked with, that pretty much seals the deal that that's an amazing letter. So if you don't have those other pieces of your application, then I'm going to pass. And it's hard because, like I said, 300 of the 400 applicants have those pieces of the application in some form, are excellent. And so to try to narrow that down, we interview approximately 60 people every year for our 4 positions. And to try to narrow that down is sometimes a little bit of a, difficult thing. And it's also interesting because I hear it from applicants all the time after the process. They say, yeah, I can't believe I didn't get an interview to XYZ program, but I got an interview to this other program. And it just, I don't know why. And I always tell them, yeah, we don't really even know why. Maybe I was in a great mood when I read your application, or maybe you had some sort of phrase in your personal statement that resonated with me, or maybe your volunteer activity was something that I participated in when I was a medical student, right? And so it's hard. We do somewhat rely on geography as well, because clearly somebody who we only have one resident right now in our program who is from the Northeast, because we're in Colorado. So someone who is from the Northeast, who is exactly the same as someone who's from, Oklahoma, we're probably going to interview the person from Oklahoma just because they're more likely to actually look at us as an option for their training.
And it seems like the idea is very similar to medical school. It's like, oh, I don't want to interview you and accept you if I kind of have an idea that you're not going to come here.
Right. So there are things that, each program has their own pros and cons, right? Each program has their strengths. And if there's something about our program that you are really interested in, let's say that you feel like you like plastic surgery also, and you really want to train in how to do cleft palate and reconstructive work, we're one of only 5 programs in the country that offers cleft palate training in our pediatric hospital. So, that may signify that you're more interested, but it's always hard to tell because, people look on our website, as they should, and see what we're about. And how do I know that it's a real interest versus something that, you put in there to try to get an in, and I don't blame them for that. Like, I actually applaud that. I think that's smart. You do what you need to do to get where you want to go, but it's also tricky from this end to really know what people's motivations are.
How should a student be evaluating programs? It seems like potentially more and more, just like with medical school applications, residents or medical students are just kind of shotgunning and applying to as many programs as possible.
Yeah, and I don't think that our websites, I mean, I can't speak for other fields, but I know for otolaryngology, I've looked at multiple websites, and I don't think there's a lot of information that helps you make that decision. I think a lot of applicants apply geographically, if they have family in the area or it's somewhere where they want to be for other reasons. I think it's an interesting process of how people decide, what are top tier programs too, because in otolaryngology, there are very few programs that are actually better than other programs. When you have such as competitive specialty, almost all of our 120 programs are actually amazing. There's a few every few years that are struggling. Maybe they're chair left and other people left with them. So their, faculty is decreased, or they're missing a certain subspecialty for a few years because of recruitment issues. But other than that, 99% of our programs will give you excellent, amazing training. And so it can be really hard to know what you're looking for because they're all very similar. I don't think you get a great idea of what a program's truly about until you go there and see how you fit with the culture and the residents, more specifically in the faculty. But I can't interview 300 people, so it's hard to figure out who to interview, and it's hard for applicants to figure out where to apply as well.
Yeah. What's the application process like? Are they applying to categorical programs, or do they have to do separate intern years? What does that process look like?
Yeah, it used to be a separate intern year, but now it's combined. So, and most of our interns are very happy about this fact. They do 6 months of ENT, which it used to be a complete general surgery here when I went through residency, but they love that it's actually 6 months of ENT now. So they generally apply just for a categorical position, and it's 5 years. And then we arrange the other 6 months of intern rotations with other departments. It's actually very prescriptive through the ACGME what rotations the interns can do. And so we keep that in mind and set those up.
What does the rest of the residency path look like?
Yeah, so most programs will have a research block during their training. It's usually somewhere between 4 and 6 months during third or fourth year, sometimes second year, but usually a little later. But other than that, you are doing clinical work the entire time. So as a junior resident, you're going to do more clinic at most programs. As a senior resident, you're going to spend a lot more time in the operating room. And it's really a progressive autonomy experience as well. So as a junior resident, you're going to generally have a backup call person that covers, is there for questions. And then as a senior person, you're going to be the main person assessing the patient and then signing out to your faculty.
What does call typically look like? Is it kind of stay at home, answer the phone, or are you in the hospital most of the time?
Yeah, so I think it depends per program. All of the programs that I've been a part of, except for one actually over the years, either in training or as faculty, were home call. And I think that is the trend. I think most programs are like that because we generally cover several hospitals at once. So our program, for example, we cover 4 institutions, and there's a junior resident on primary call. They're the first person who gets called, and then a senior resident to back them up in case something needs to go to the operating room or if they're just overwhelmed with multiple emergencies at multiple hospitals. I would say that it's very rarely a home call. It's actually car call because you're driving to all the hospitals all the time. And, we've actually arranged to have call rooms for our residents at the various hospitals as well, because they actually are there a significant amount of time. And if you're waiting for the operating room, and a case is going and it's not going to go for an hour, you're not going to want to drive home and then come back, so you can stay in the call room for that hour and hopefully get a nap.
When it comes to, oh crap, I just blanked on my question. I know where I was going. The power of editing. And just random side note, when I first started podcasting, I didn't know how easy it was to edit audio. And so I would start an episode just by myself. And I would get 10 minutes in, screw up, and then start all over. It's awesome.
Yeah, I love my editing software.
Yeah, it's fun. All right. For a medical student, when they're thinking about kind of getting in front of program directors, getting in front of you, and they want to come to your program, what are your thoughts on doing elective rotations away from their home program?
That's actually interesting. So I published an article about this because I was curious about applicants' perceptions, because I have clearly perceptions, but I wanted to know what other applicants thought. And so about 2 years ago, I did a project with one of my residents at the time who's since graduated. And we sent out a survey to applicants asking them about away rotations. And what we found was that 90% of people actually thought the rotation was valuable, not necessarily because they all matched at their away rotations, but because they learned so much about the field and about another program so they could compare it to their home program. So, it's a double-edged sword, right? So doing an away rotation, I'm a fan of doing an away rotation. You're interviewing for a month, which is harder to do than interviewing for a day. Almost anyone can put on a face for a day, but doing so for a month is very difficult. And so you're going to be probably judged a little more harshly over that month. However, if there's some place that you really, really want to go, having an away rotation is pretty much your only guaranteed way of getting an interview there. And even then, it's not guaranteed to get an interview there because not all applicants get interviews at their away rotation if they didn't do a good job. But with the way that selection goes and with so many great applicants every year, it's a little bit random what interviews you're going to get. So if there's a place you really want to go, I would highly recommend that you do an away rotation. And it does influence rank lists. So a lot of people who do an away rotation and do a great job match at that away rotation. And, even if it doesn't work out, so, I did an away rotation, I didn't match there, but it gave me a lot of insight into how a different department operates and how residents interact with each other at different places. So you could really hone in on that during your one-day interviews and see what you were looking for in that way, what kind of a fit you were looking for, and what kind of questions to ask that you may not have thought of because you've only had this one experience at your home program.
Now, I'm sure you're getting a ton of feedback from your residents about the students who are doing their rotations. What are the things that a resident's saying when you go, okay, that's going to be a good future resident?
Yeah, so I think it's the applicant who shows up on time, shows up early, carries around supplies, right? So wound supplies, tongue depressors are key. A flashlight is key for looking in dark recesses of the oral cavity. So it's someone who really clearly wants to be there, is asking intelligent questions, is volunteering to do some of the things that are tough to do, like pull a drain or talk to the patient who is unhappy because they're suffering, and making them feel heard. So those are the applicants that we really look for. I think what the residents have to say is ultimately more important to me than what the faculty have to say. Every year or every other year, we do have an applicant who comes and they are two different people. So they act one way with the faculty and then they act a completely different way with the residents. And that's a huge red flag for me because if the residents really don't think you're a hard worker and you're just trying to sneak under the radar, and the faculty all love you, I don't want that type of resident in my program.
Yeah, that's interesting. For the osteopathic medical student listening to this who wants to go and be an ENT, what does he or she need to do to help kind of stand out from the crowd?
Yeah, that's really interesting because last year, the ACGME incorporated the DO programs into the NRMP match.
Yep.
So we actually went from, I think, 110 programs to 120 programs, and the number of positions increased by like 20 positions, which is, again, very rare for that to increase by that much per year because they incorporated a lot of the DO ENT programs. Mm-hmm. So I think it's going to change significantly having one standardized process for application. I think there's going to be a lot more crossover over the next, 5 to 10 years. I think, like any applicant, if someone has, an excellent application, they've got a good board score, they've got good clerkship grades, good letters of recommendation, some research, I think that they would be, evaluated in the same way as an allopathic applicant.
Do you see any major changes coming to the field of otolaryngology that a student interested should be aware of?
As technology advances, I think we're going to have even more interesting toys to play with. So we already have lots of toys like endoscopes and binocular microscopes, all sorts of things that allow us to see into the dark crevices of the ears, nose, and throat, where I think that's going to advance even more as technology continues to advance. But I think the ultimate ability to interact with patients and the ultimate patient-physician relationship is not going to change. And I think as we go to a more kind of lifestyle-based, not being the single, otolaryngologist in a community, but actually having bigger practices, more, less mom and pop shop physician offices. I think that that's really the barrier that we need to address, is still having patient connections and still having patients feel heard and feel taken care of by each provider in a way that feels more one-on-one.
For the majority of surgical fields out there, they are still very heavily male dominated. For a female listening to this, wanting to go into ENT or another surgical field, what words of wisdom would you have for her to navigate this process, to have her voice heard?
Yeah, I mean, part of the reason I am staying in this field and don't just stay home with my kids. Well, the main reason is because I would go crazy. But the second reason is because I believe in showing applicants, female applicants and residents, that it's possible to have a life and to have a career. I think that having women in surgical fields is critically important. I think that some patients do find that they want their doctors to look like them, whether that's a gender thing or a racial and ethnic thing. I think it's important to have a diversity of, physicians in our field. And I think that otolaryngology is a little bit behind the times as far as both gender disparities and racial and ethnic disparities. There's data to back that up. I think the main thing is to realize that yes, surgery may not be as predictable as a non-surgical field, but you can make that into what you want by choosing the right job after residency. Residency is always difficult, no matter what field you go into. Surgical specialties are generally longer than non-surgical specialties, and that's going to be the toughest few years of your life from a work standpoint. But if you can get through that and you can accomplish the knowledge base that you need and the skills that you need, you can actually have a lot of room for to decide what you want your life to look like afterwards. So, for me, I work full time. I'm married to another surgeon. I have 2 small children, and I make it work. Does that mean that I am always home every single night for dinner? No, it doesn't. But does it mean that I'm home 5 nights a week at least? Yeah, I am. And I make that a priority. Does it mean that I can do all this without help? No, we have a nanny. We have, a person who cleans our house. It's not something that you can do alone, and you have to have support, but it's definitely possible.
Any last words of wisdom for the medical student who maybe just got back their step 1 score and didn't do as well as they hoped, but still wants to progress forward and become an ENT?
Yeah, I would highly recommend that you seek out a mentor. So, someone who is on the application committee, the program director, associate program director in your institution. If you don't have an otolaryngology program at your institution, seek out one in a nearby area or institution and talk to them about the reality of applying, because as program directors in this field, we all know what it takes. This is an amazing field. I love being an otolaryngologist. I love, being an academic otolaryngologist and program director. And if you feel like you didn't get the score you wanted, that doesn't mean that the dream is over. It means that you need to have other things that make you an amazing candidate. And having a mentor to help you through that process is really critical. And most people who you ask want to help. They want to see you succeed. And so don't be hesitant because you feel like you might be a bother. I always have students who I advise, and they're always like, oh, so thank you so much for taking the time. No, this is what I live for. This is why I'm an academic otolaryngologist. I want to help, and I want to see the next generation succeed, because at some point I want to retire. And so I'm going to not be able to do this anymore. So I want there to be good people to take over from me. So, yeah, I think that's really key. And I think don't use a step 1 score to judge yourself or your potential. Meet with someone and get real advice about what else you need.
And real advice, speaking of mentors, you are a newly christened podcaster with your Oto Mentor podcast. Talk about the Oto Mentor podcast and how students can listen to that.
Yeah, so a few months ago, I thought this is going to be really fun. I want to do a podcast for otolaryngology. I looked around, and most of the otolaryngology podcasts in existence were from journals where they highlighted excellent articles, which is a really great thing. But there wasn't really any mentorship type podcasts within the field that I could find. And so I thought, why not? I recently got promoted to associate professor. And so I have the luxury of time before I apply for full professor to do some fun things. So I decided I'm going to just try this and see how it goes. So it's a one-on-one interview-based format, kind of like this one, where I talk to other otolaryngologists about different topics. So far, there's 3 episodes posted, and I hope many more in the future about advice for residents and medical students, and hopefully eventually advice for even junior faculty, how to advance in your field, how to choose a fellowship, how to apply to otolaryngology as a specialty, the nuts and bolts of what your personal statement should look like, and those kinds of things. And, we'll see where it takes me, but I'm really excited about it.
And how can they find it?
It's Oto Mentor, OTOMENTOR, and it's on iTunes and Spotify. So you can just search for it and download it.
All right, there you have it. Another amazing guest. Great discussion all about otolaryngology, especially for you as a medical student if you are interested in matching into otolaryngology and what you should be doing to make yourself the most competitive applicant possible. If you would like some more information from Dr. Cabrera-Muffly, go check out her podcast at Oto Mentor. Again, that's Oto Mentor. Find it on Spotify, Google Podcasts, Apple Podcasts, probably wherever you are listening to this podcast right now. Thanks for joining me today. I hope you have a great week. We'll see you next time here on Specialty Stories.
This is MedEd Media.